Welcome to this explainer. Today, we're taking a microscopic journey. We are going to break down tuberculosis, literally from the very first moment of infection all the way to the definitive cure. Think of this as a clinical true crime analysis. If you've ever wanted to understand exactly how this invisible airborne enemy operates, and more importantly, how modern medicine totally defeats it, well, you're in the exact right place. Let's get right into it.
Okay, here is our roadmap. First, we'll look at the invisible airborne invader. Second, we go inside the infection. Third, diagnosing the disease. Fourth, the road to cure. And finally, recovery, prevention, and hope. But before we get bogged down in all the heavy biology, I really want to anchor us in one incredibly reassuring fact. Tuberculosis is preventable, treatable, and entirely curable when it's diagnosed early and treated correctly. Everything we look at today is built right on top of that clinical reality. Because as intimidating as TB sounds, it is a battle we know exactly how to win.
Part 1. The Invisible Airborne Invader.
So let's meet the culprit. It's a highly contagious bacteria called Mycobacterium tuberculosis. These bacteria hitch a ride on inhaled airborne droplets, and they travel on a very specific path. From the nose, down the trachea, past the bronchi, and they settle incredibly deep into the lungs. They literally bypass the diaphragm and park themselves directly in the alveoli. And that spot, that is absolute ground zero for a TB infection.
Now, we know TB is strictly airborne, right? It spreads through coughs, sneezes, laughs, or even singing, activities where these tiny droplets can actually linger in the air for hours. But honestly, there is immense relief in knowing how it doesn't spread. You absolutely cannot catch TB from hugging a loved one, or sharing a meal, or shaking hands, or touching surfaces. That's a huge myth, completely busted.
Part 2. Inside the infection.
Which leads me to ask, what exactly happens the moment these TB bacteria actually enter your lungs? It becomes this scene of immediate microscopic urgency where your immune system suddenly clashes with this invader. So let's break down that biological cascade.
Step 1 and 2, as we just mentioned, are the inhalation and the arrival of the bacteria down in the alveoli. At step 3, your immune system realizes what's happening and launches a massive response. Step 4 is absolutely critical here. Your body attempts to wall off these invading bacteria by building these microscopic cellular prisons known as granulomas or tuberculosis. And this brings us to a huge crossroads at step 5. Either the bacteria stay inactive and walled off, which we call latent TB, or they break out, multiply, and start causing real lung damage. That is active TB.
Now, latent TB isn't contagious, while active pulmonary TB is highly contagious. But here's the thing, TB doesn't just stick to the lungs. Extrapulmonary TB targets entirely different organs. It can attack the spine, which is clinically known as Pott's disease, or it can infect the brain, resulting in TB meningitis. And then there's miliary TB, where the bacteria spread rapidly through the bloodstream to multiple organs at once. Make no mistake, miliary TB is an absolute medical emergency.
So who is most at risk for this? Well, environmental factors like overcrowded living spaces with poor ventilation play a huge role, especially when combined with systemic factors that weaken a person's immunity, things like HIV, diabetes, or malnutrition. It just makes invasion so much easier. You really need to watch for symptoms like a persistent cough that lasts more than 2 or 3 weeks, fever, night sweats, and unexplained weight loss. And more importantly, you must recognize the immediate emergency warning signs, things like severe breathing difficulty, altered consciousness, or coughing up blood, which is clinically called hemoptysis.
Part 3. Diagnosing the disease.
Thankfully, our primary diagnostic arsenal is strong. It starts with a standard medical history and a physical exam. Then, a chest X-ray is commonly used to reveal upper lobe infiltrates and cavities. For the really complex cases, we bring in the CT scans. Down in the lab, sputum smear microscopy is used to detect acid-fast bacilli. But the absolute gold standard, the way we definitively confirm the presence of the bacteria, is a sputum culture.
But the really crucial point I want to highlight here is the technological brilliance of a tool called GeneXpert. This rapid molecular test is a total game changer, seriously. It doesn't just detect the presence of TB bacteria quickly. Crucially, it identifies that those bacteria have already mutated to become resistant to our frontline drug, rifampicin. Getting that data immediately completely shapes how doctors plan the medical counterattack.
Now, you might be wondering, what about when the enemy is hiding silently without any symptoms? Well, even for latent TB, we have incredibly precise tools. The tuberculin skin test, also known as the Mantoux test, or the IGRA blood test, are used specifically to sniff out those inactive bacteria. And I should note, it's also standard protocol and just vitally important to conduct concurrent HIV testing, simply because the two diseases heavily impact one another.
Part 4. The road to cure. So let's break down exactly what that treatment protocol looks like. The rigorous standard anti-TB medication timeline takes a minimum of 6 months to completely eradicate these tough bacteria. It kicks off with an intensive phase for the first 2 months, using 4 heavy-hitting drugs: isoniazid, rifampicin, pyrazinamide, and ethutol. After that intense start, the patient enters a continuation phase. This usually lasts for 4 more months, where they are strictly taking just isoniazid and rifampicin.
Now, I really need to deliver a very stern warning here. You absolutely cannot stop this treatment early just because you suddenly feel better. Actually, stopping early has catastrophic consequences. Not only does it lead to treatment failure and continued transmission, but it literally creates mutant strains. It gives rise to multi-drug-resistant TB, or MDR-TB, meaning the bacteria just laugh off frontline drugs. And even worse, it can lead to XDR-TB, extensively drug-resistant TB, which is incredibly difficult to treat.
Because that 6-month medication marathon is so grueling, public health experts developed this brilliant safety net called Directly Observed Therapy, or DOT. Under DOT, healthcare workers actually directly supervise patients as they take their medication. It's such a simple concept, but it's an incredibly effective system. It ensures patients don't miss a single dose, drastically improving treatment success rates, often pushing them way above 85% globally, and it prevents those super dangerous resistant strains from ever developing.
Part 5. Recovery, Prevention, and Hope.
For any of the physiotherapy students or caregivers joining us on this explainer, rebuilding the body involves very specific physical and nutritional goals. Physiotherapy uses techniques like diaphragmatic breathing and incentive spirometry to really improve lung expansion and breathing efficiency. However, you need to know carefully that vigorous airway clearance is not routine here. It's only used when clinically appropriate. Pairing these controlled exercises with a high-protein diet, adequate calories, and proper hydration gives the body exactly the fuel it needs to restore full physical function.
Finally, we have to look at how we defend the wider community. Left untreated, TB leaves devastating complications like permanent lung scarring and bronchitis. But just look at our prevention tools. They are highly accessible and incredibly effective. We have everything from the BCG vaccination and early diagnostic testing to simple environmental controls like opening a window for good ventilation, all the way down to personal controls like wearing masks and strict cough etiquette. It really is entirely preventable.
And that brings us to the core takeaway of this entire explainer. Tuberculosis is a very serious but entirely curable infectious disease when modern clinical science is combined with true patient dedication, meaning getting diagnosed early, finishing that complete course of treatment no matter what, and engaging in proper rehabilitation. We absolutely defeat this disease. It saves lives and it stops the spread dead in its tracks.
So I want to leave you with this final thought. We have the rapid diagnostic tools, we have the intensive drug therapies, we have the proven rehabilitation protocols. With all of this incredible science at our disposal, how will you use this newfound knowledge to spread awareness, support treatment, and help us eradicate this invisible enemy from our communities forever? Thank you so much for joining me on this explainer. Stay curious out there and keep learning.